Good afternoon and welcome to Webinar Wednesday. Today we are joined by Bin-Seng Wang, Vice President, Program Management at Sodexo HTM. Webinar Wednesday would like to thank our sponsor, Sodexo Healthcare. At Sodexo Healthcare, they build trusted partnerships with health systems to support quality care delivery. As part of their mission, Sodexo HTM helps improve patient outcomes through integrated technologies and operational efficiencies with flexible solutions to meet your needs. For more information, please visit us.sodexo.com/HTM. Just a quick reminder to save the date for our full MD Expo. We're headed to the Caribe Royal Hotel in Orlando, Florida from October the 29th to the 31st. Please join us for 3 days of education, networking, and the latest advances in medical technology products and services. Registration is now open, so for more details, please visit mdexposhow.com. Also, a copy of the pre-show planner can be found in the handout section of your webinar dashboard. Today's webinar is eligible for 1 CE credit from the ACI, and you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Okay, let's kick off today's webinar by giving away one of our Webinar Wednesday t-shirts to the attendee that can tell me the answer to the following trivia question. July is National Watermelon Month. Which state is the biggest producer of watermelons? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, our presenter today is Bin-Seng Wang, and he will be discussing how well do you know your job, test your knowledge. Now, before I hand over to Bin-Seng, just a quick heads up, audience participation is encouraged today. So Bin-Seng, whenever you are ready, you may go.
Thank you, Linda. Good afternoon, everyone, or good morning for a few those who may be on the West Coast. It is a great honor and pleasure to talk to you today. I hope I don't disappoint you too much. Before I forget, besides that t-shirt, Sodexo will be providing a number of gifts for those who participate, and that will be a raffle done after the completion of this presentation. So make sure that you participate, because that will increase your likelihood of getting into the raffle and winning the prize. Okay, so let me first give you a fair warning, because most of you probably know already that I am a notorious and infamous destroyer of religious images and your sacred cows. So I want to make sure that you understand that if you do something wrong after you attended this presentation, it's all on you and not me. Okay, and for those who do not know me, here are some biographic information, and most of that is probably just fake news put together by my published marketing specialist, so don't believe everything you see there. Okay, and this is the abstract for the presentation. No reason to read all of that. The only thing that is really worthwhile for you to take away from this slide is that we want to help you work smarter and not harder, because you work very hard already, and there's no point in doing that. Okay, some ground rules. We are going to present up to 20 tests, and with each test, after I read the test, you will have an opportunity to answer a polling, and the polling is only true or false, so it's very simple and quick, and we will give you only 10 seconds to provide your answers, and then afterwards I'm going to provide the correct answer and justify the answer. Now, if you don't agree with me, then I'm sorry, you have to appeal to the Supreme Court, where I have bribed a few justices for my own benefit, so tough luck for you. And also, please don't even try to use ChatGPT because I tried already and it provided mostly wrong answers. So to give you an idea how this thing will go, let me give you a sample test, okay? And this is American hospitals are required by CMS and therefore Joint Commission, DMV, etc., to complete 100% of scheduled or planned maintenance on all, not just those classified as critical or high-risk equipment. True or false is your choice. And we are not going to do the polling because this is just a sample. And then after the sample, I'm going to say, hey, this is a true statement. And because the CMS, Centers for Medicare and Medicaid, has determined, and actually Joint Commission had to put 2 notes under its standard and say that all equipment, doesn't matter whether it's maintained per manufacturer recommendation or using the alternative equipment maintenance AEM program, you have to have 100% completion rate. Okay, so are you ready to go? Okay, let's get started. First test, an electrical safety test, EST, must be performed at each scheduled maintenance or PM, if you want to call that, if it is recommended by the respective manufacturer, even if the equipment is in your AEM program. True or false? So poll.
Okay, I'm going to close number 1.
Okay, the answer is false. Okay.
You had 55% that said true, and you had 45% that said false.
Ooh, half and half. Okay, it's false because there is no evidence, first of all, that any patient has ever been harmed by electrical shock, except in very unusual cases, I won't discuss here. But most importantly, the National Fire Protection Agency's Standard 99, which has been adopted by CMS and most states, states very clearly that outpatient care related electrical equipment shall be tested before being put into service for the first time and after any repair or modification that might have compromised the electrical safety. My emphasis in color, the original text is shown here. So you don't have to perform that during PM, really, because you did not do any repair. And if it's not the first time before you put that piece of equipment into service, it's not required. So it's fake news, sorry. Okay, number 2. To decide which pieces of equipment should be classified as critical, that's the CMS term, or high risk, that's the Joint Commission term, one should use a classification scheme like the Fennigkoh and Smith method, more widely known as the risk-based criteria. True or false? So open the poll.
Okay, I'm closing that, and your answer is 78% true and 22% false.
Well, let me first refresh your memory about what is the so-called risk-based criteria. It's a simple equation. If the number total EM is above 12, you include. If it's lower than 12, you don't include. And in order to do that calculation, you have a table, etc. But unfortunately, this is false. At the time it was introduced some 30 years ago, it was a very good tool. However, nowadays it is not really appropriate because that particular equation is not a real reflection of what the concept of risk today. Risk is composed of severity and probability. The Fennigkoh model is basically based on severity. It's the function of physical risk, and the probability data was not available, was not used at that time, and it continued not to be used today. Your schedule maintenance PM is primarily determined actually by the technology used in that device and not by the severity or even risk of that piece of equipment. The few exceptions are those very small number of cases where you can use the safety and performance inspection to detect hidden failures and potential failures that would justify you to continue performing the so-called PMs, or so-called because they are not really preventive, they are just planned maintenance. So in the past, we have known that equipment that have more issues, and so we really need to use our own experience, our own knowledge about equipment to determine what should be considered critical or high risk. And by the way, as Linda said, there will be an upcoming MD Expo in Orlando in October, and I'm going to present some real data for you to see how your knowledge about equipment is really going to allow you to schedule your maintenance more appropriately. And just to give you an example to hopefully convince you that high risk does not mean high maintenance, is that ICU monitor by definition is high risk because the patient would not be in ICU if it's not intensive care. But it does not require high maintenance because it's a purely electronic piece of equipment and you can run it to failure. It doesn't make any significant difference. Actually, I'm going to quote the former Director of Engineering at Joint Commission, George Mills. He said in public in one of the conferences that high severity does not mean high maintenance, high scheduled maintenance. So sorry, that's fake news. Okay, next one. Reliability center maintenance, RCM, is the best strategy for equipment to be used in the alternate equipment management AEM program. Okay, poll 10 seconds.
Okay, you've got 65% true and 35% false.
Okay, I guess I'm going to have to contradict quite a few people here. What is the RCM process? We first have a step called planning. We have to select the assets, analyze. The most important one is look into the failure mode effect of that particular piece of equipment, and then define the maintenance schedules and work instructions to cover that piece of equipment besides the training, etc. And then we have to implement that and then evaluate the results. And if the results show that the maintenance cannot reduce the risk of that piece of equipment causing harm to patients, you have to redesign. This RCM concept is not mine. This is from many years of experience and publications about this. The challenge here is that we most often cannot determine the FMEA of the equipment because many of the devices nowadays have built-in software and the software is completely transparent, hidden from us. And the manufacturers very often don't provide us anything with clear indication why the schedules and work instruction activities are necessary. Many of the OEMs don't even provide us with the service manuals at all. I don't know what is your particular experience, but I have had a lot of challenges. And at the end of the day, if nothing works, we cannot do the redesign as prescribed by ICM because this is a direct violation of the Food and Drug Administration's regulations and the law that is the Food and device laws. So you guys need to be very careful about this. So bottom line here, this is false. RCM became popular and it was mentioned by CMS in that memorandum that was issued back 10 years ago, 2013, but it was because it was misunderstood and misquoted by that CMS document. It said that a RCM is a maintenance strategy, blah, blah, blah. The sentence here, I'm not going to read in total, but if you read it, you will see that this is nothing but a rephrasing of the Fennigkoh-Smith model that we discussed previously. And at the end of the day, the real process is what I showed you before, and it's not really feasible, unfortunately, for us to carry out full medical equipment because of the limitations that we have, being blind to what is hidden inside the equipment in terms of software and to some extent even hardware as well. Okay, let's go to number 4. Evidence-based maintenance, EBM, relies not only on the observed history of failures, but the theoretical probability of certain types of failures. This second type of analysis, the probability analysis, is typically beyond the capabilities of most service organizations. Okay, Paul, 10 seconds.
Okay, you've got 47% true and 53% false.
Gee, we have a very interesting split of the community here. Okay, let's review quickly what is evidence-based maintenance to refresh your memory. I'm not going to read this definition here because I am more a visual person than a word person. So let me show you some pictures. I like to fish, and this is my tackle, and this is known as structure in terms of healthcare, because evidence-based maintenance is obviously copied shamelessly from evidence-based medicine, and so I'm using the same names. The process for us performing maintenance is what is known as fishing, throwing the lure out to try to fool a fish. And then if you catch the fish, you have an outcome, the clinical outcome in the case of evidence-based medicine, that is used to judge whether a particular process, therapeutic process, surgical procedure, etc., it is good or not. So that is what this is about. And the way to collect information, analyze information, is using the so-called failure cause code. The important word here is cause. We don't want to know whether the power supply fell or not, because that is something that is a fact, but which cause created that power supply failure? It was because a thunder struck the building and burned the power supply, or because the power supply burned itself out after many years of use. So we need to understand, and in particular, we have 4 categories of failures: service-induced failure, hidden failure, potential failure, and preventable, predictable failure that are within our HTM control, and we need to pay particular attention to them and make sure that we don't let this kind of thing slide. But there are many other things, for example, unpreventable failure, normal wear and tear, there's nothing you can do about it, and you just have to bear with it and maybe hope to buy better, more durable equipment in the future. So when we compare AEM against manufacturer's recommendations, OEM, you can see we can collect the statistics of the cause of failure using the causes at the bottom here and the statistics at the top. Basically, the average and standard deviation that are plotted here. You can see this is a pretty rudimentary, simple statistics that you probably remember from your high school days. And bottom line here, that statement was false, because you don't need. This statement was actually made in the AMI EQ 89 2015 edition, but there was some misunderstanding by someone there who thought there was a theoretical probability. No, the probability is empirical, based on data, and is not difficult in terms of statistics that you need to know. I think everyone knows what is an average, and you may struggle a little bit with standard deviation, but that is nothing really challenging. So as I said before, EBM is a shameless copy of the clinical evidence-based medicine, and this is the so-called cohort study approach used in that in medicine, and is something easy for you to explain to your clinical colleagues And actually now this is not only implemented in the United States, but in Italy, Brazil, and South Africa. And so really nothing extraordinary about it. Okay, let's go to test number 5. CE productivity, CHTM productivity should be measured by the ratio of work hours documented in work orders and the total number of hours paid after subtracting holidays and vacations of the staff. True or false?
Okay, you've got 41% true and 59% false.
Jeez, we have a very even split of our audience here. Okay, let's see. Productivity, the real news, what is really happening. This is a seemingly good confirmation of what was stated previously, and this was acquired from a report generated by something called Action OI that's used to be part of the Truven and then went to IBM, etc. And now I think it's managed by one of the group purchasing organizations. And this really looks very good and maybe even a little bit too good. So I did a study of 10 years of such information with my prior employer called Aramark, and turned out that it's definitely nothing that looks like that. And the reason is very simple. In the beginning, no one paid much attention, but when we started to look at the data starting around 2006 and proceeding from there, the staff said, oh, you really are looking at that. You want me to put those numbers in there? I will give you the numbers that you want to see. Lies, damn lies in statistics. You probably heard that phrase before. So this is nothing but fake news lie, because the number of hours documented is nothing but self-declared. No one is really scrutinizing what is entered, and so you get what you ask for. And also, if you stop and think for a minute, why are you awarding people who are your slowest worker in your institution? The United States Bureau of Labor Statistics does not define productivity that way. They define productivity as the ratio of the output of goods and services to the labor hours devoted to the production of that output. So if you want to measure, your numerator should be the number of PMs, corrective maintenance, recalls, and other works that were performed by the staff proportional to the number of hours they actually worked or you paid them, okay? And not because they logged a lot of number of hours and did nothing but tweak their thumbs during that time. So another detail that you need to remember is that the so-called non-productive hours actually is very important, because those are typically roundings with clinical staff that is very effective, productive in reducing service calls and downtime, because very often they are not fully aware how to properly use the equipment, and also this will help you and the staff obviously enhance patient safety. So don't fall for that productivity concept that is totally wrong, okay? Okay, number 6, daily or per shift defibrillator testing is needed for verifying its proper function and the status of its internal battery, and thus should be performed with the defibrillators unplugged from the outlet. True or false? Polling.
Okay, we've got 58% true and 42% false.
All right, we definitely are split in the middle. Okay. Sorry, guys, false, bad, fake news. The reason defib testing was instituted in hospitals and other healthcare environments is because you want to be sure first that defib is in the right place on the crash cart, because otherwise in an emergency, the staff cannot find it. And second, the staff needs to practice using it in order to be sure they can use it. This is the same concept that is done during emergencies for fire drills. Most people don't know how to use a fire extinguisher if there is a fire in their kitchen. Okay, so this is exactly the same thing, and this is not my saying this. There is a publication by leaders in patient safety, and you can read this yourself. Okay, so testing with defib unplugged is not necessary because you are actually using only a small fraction, approximately 1% of the energy stored in that battery. So you are not really verifying this condition of that battery. And if you tell them to unplug the defib to test and they forget to plug it back afterwards, you run the risk of discharging the defibrillator slowly, and when it's truly needed, it's totally discharged, and then you are really creating a safety hazard for your patients. So please don't do that. Test number 7. In equipment replacement planning, one should use the American Hospital Association publication called Estimated Useful Lives of Depreciable Hospital Assets as the main criteria. True or false?
Okay, we've got 78% false and 22% true.
Oh, finally you are getting somewhere. Good job, folks. It is false because, as the name indicates, it is for depreciation calculation mostly. In other words, it's a financial accounting purpose. It does not really have any real relationship with the so-called useful life. Actually, we did an analysis among the equipment, 0.5 million pieces from about 100 hospitals managed by Sodexo. And as you can see on this graph, the vast majority of equipment were used far longer than the depreciation schedule proposed by AHA. I'm not saying that they did anything wrong here, please understand. Depreciation, it is necessary. Actually, that table is mandated by CMS for hospitals that participate in Medicare Medicaid program to use that table. That's perfectly fine, but it's not a justification for you to go out and replace equipment. Just like you should not use the depreciation schedule to replace your cars. Most cars actually run a whole lot longer than you may want to depreciate. Okay, next one, number 8. It has been proven that CHTM has enhanced safety and effectiveness of not only medical equipment, but also the care of patients. In other words, you have made the care safer and the clinical outcomes better for the patients. Polling.
Okay, we've got 81% true and 19% false.
Okay, we're getting somewhere, but this time here, I hate to disappoint you, it is not true. The reason is very simple. In order to provide safe and effective care, it's not sufficient to have safe equipment. Equipment is nothing but a tool. It's like your hammer, your screwdriver, etc. The equipment must be used by the right user, on the right patient, at the right time, and in the right manner. If you use your screwdriver, your hammer in the wrong way, you can actually even hurt yourself. Okay, if you don't have those 4 other rights, safe equipment by itself is not enough. It is part of the requirement of the right things to do, but it's by itself not enough. Also, the equipment has to be reliable, and that is part of our duty, because if the equipment is down, has long down times, etc., you may hurt the equipment in the patient indirectly, because the clinicians cannot provide prompt and timely care, even to the point sometimes of diverting the patient to another place because you are then denying care to the patient because the CT is not working, for example. Okay, so we definitely have the duty to ensure the equipment is reliable and safe to use, but also available. But we cannot claim that we made the patient safer and better. Patient safety ultimately is the responsibility of everyone in the healthcare industry, just like passenger, I should say, safety is responsibility of everyone in the transportation industry, not just the people who maintain the aircraft or the train or the bus or anything. We are just in the same boat as everybody else here in the other industries. Okay, number 9, the cost of service ratio, abbreviated as COSR, is ratio between the service cost and purchase cost, is the best financial benchmark for CE or HTM benchmarking. Polling, please.
Okay, we have 25% true and 75% false.
Again, the split is getting better. Okay, so let's take a look from an analogy from a totally different industry. Automobiles, specifically SUVs. On this plot here, this solid line here shows the price, the MSRP of a number of different vehicles, ranging from the more common ones to the more sophisticated, expensive ones, all the way to Porsches and Land Rovers, etc., with one totally electrical vehicle mixed in between. The cost of the maintenance cost divided by MSRP is represented by this dotted line. As you can see, although the cost of maintenance does increase with the price of that car, the SOV, the ratio actually decreases because the rise of the price of the car is faster than the cost of maintenance. And in particular, the technology change made a huge difference here. Doesn't matter whether you buy a totally electric, let's say, Toyota RAV4 versus a gasoline-powered RAV4, you'll see you don't have to spend that much time and money doing maintenance, because there is no oil to be changed for the engine or for the transmission, because there's no internal combustion engine anymore. There's no transmission anymore. Everything is electric motors. So there is no real reason that the cost of maintenance is really dependent on the cost of the equipment. The cost of fancy equipment is really just the prestige, the nameplate. If you take out the Porsche name and put a Honda name on it, the price would drop dramatically simply because of that name change. Okay, so let's take a look what is real data here. This is the cost service ratio from American Acute Care Hospital. So wow, this line of 5% looks pretty damn good, including the very high-end hospitals that have those high cost investment in medical equipment. However, if you look in a slightly different picture here, instead of acquisition cost, you look at the patient discharges. This is, after all, the output of the healthcare organization. You discharge patients, and that's how you earn your revenue, right? And you see now things have changed. The elite major teaching hospitals, like the ones, for example, Johns Hopkins, Mass General Hospital, Stanford Hospital, etc., they have much higher costs of medical equipment maintenance per discharge than the rest. And this is because they have more equipment than your other typical hospitals in this range here, because they are teaching hospitals and they want the most sophisticated, the most feature-laden equipment, and so they spend a lot of money, and sometimes they don't use that often, but they still needs to be maintained. So be careful how these computations are calculated. Again, you could be misled, and so there is no reason for the service cost to be related to purchase cost, and also both numbers are easily manipulated because very often, as you know well, the HTM department does not count the service contracts for imaging equipment and laboratory equipment in their budget. So their numerators look very good, but in reality, they don't include all the costs. And also the denominator sometimes is subject to manipulations or miscalculations because they may or may not include accessories. And by the way, if you talk to the colleagues in those very elite prestigious hospitals, you'll see that they pay actually very little for brand new, the most sophisticated equipment when it was first introduced into the market, because the manufacturers want to use their names to go to the neighboring hospital and say, hey, Johns Hopkins, Princeton, or Mater just bought this equipment, and you really need to compete with them. So you really need to use audited data and multiple data. If you don't use multiple data, it's like your GPS in your phone able to see only 3 or 4 satellites. You are going to be misguided, and you really need multiple. And this is shown here when we did a model using multiple data sets, and we can predict pretty well what is happening, except some of these elite hospitals, they have very, very unique circumstances. Number 10, in addition to imaging radiological equipment, medical lasers and new equipment, all those pieces of equipment are not allowed to be included in the AEM. How about the laboratory equipment? Regardless of size and complexity, for example, balance, optical microscope, fluid warmers, and analyzers, I'm saying must be maintained per respective manufacturer's recommendation. Is that true or false?
Okay, we got 47% true and 53% false.
There are a lot of people on the fence here. All right. Sorry, guys, it's true. Yeah, you can say that CMS does not require, but there is something called the Clinical Laboratory Improvement Act, abbreviated as CLIA, passed in 1988 and codified in this CFR. And by the way, that is a law, so it's even higher order than CMS or Joint Commission. And even the CMS in its 2013 memorandum said very clearly that you can adjust your maintenance, inspection, testing frequency, etc., unless there are other federal or state law or hospital condition of participation that requires adherence to manufacturer recommendation. Since this is a law, you don't have a choice. So be careful, my friends. Laboratory equipment has to be 100% performed, maintained per manufacturer recommendation. Test number 11. Whoever assembles X-ray machines or replaces certain parts inside such machine must report the assembly or replacement to the FDA and state agencies if required. Polling, please.
Okay, we've got 77% true and 23% false.
Oh, good, but unfortunately wrong. It's false. And this may be not your fault because this was a very recent change made by the Food and Drug Administration back in the beginning of the year, January 17th of 2023. It made a revision to the old regulation saying that the specifics requirements of blah, blah, blah are not applicable anymore to the assemblers of X-ray diagnostic, X-ray equipment, etc., etc. This is a reversal of something like 30-some years old regulation because FDA felt really this is totally unnecessary, useless, and giving them more burden than use. Actually, I actually had experience with a state representative of the FDA saying, what the hell are you doing sending me these reports? I have no use for those things. I don't want those things. And I told them, sorry, it's your boss back in the I should say Maryland that required me to send this. If you don't want it, toss it into the trash, but it's my obligation to send this to you. So previously it was required. Now be careful, the state radiation protection agency may still require it. You still need to actually fill the report and file it in your own files and then provide a copy to the state radiation agency, but you don't need to send it to the FDA, okay? All right, number 12. All the test and measurement equipment values collected during scheduled planned maintenance and at the completion of repairs must be recorded in the work order, true or false?
Okay, we've got 42% true and 58% false.
Oh, people are sitting on the fence on this one. Okay, it's false. Good for those who remember that actually NFPA 99, which as I mentioned before, has been adopted officially by CMS and therefore Joint Commission, DMV, etc., says there is a log of test results that you need to maintain. However, it has in its appendix a note that's this clarification that there are several approaches, documentation, blah, blah, blah. At the end of thing, it says, basically, you can thereby minimizing technicians' time in recording the values of each measurement taken because only the values that need to be recorded is the failure or deviation from the requirements of the chapter that was detected when the corrective repair was undertaken. In other words, this is the so-called exception reporting. If it's stated here, exception reporting. In other words, if it's falling within the specified range, you can simply say PM passed or pass the CM testing at the end of your repair, and therefore nothing needs to be done. Okay, you don't need to write down those numbers. And by the way, this is not only saving time, but also saving you most likely a lot of headaches down the road because someone can fat finger in a wrong digit. And when you have a litigation in your hands and the plaintiff's lawyer said, how come you release a piece of equipment that was out of range? You are going to be in a very tough situation to answer that question because how do you know that it was fat fingerly wrong or it was indeed a out of range number? Unless you have an automated way to collect that number and put it into your CMMS, don't even bother to do it because you are not required to do it. But if the number is out of range, you need to record it because then you need to fix it, okay? Now, there is an exception to this rule here because under the FDA's rules, the so-called quality system regulations, the manufacturers and their staff are required to record all those values when they service equipment that they produce. If it's equipment that they did not produce, like a multi-vendor service situation, they don't have to do that. But if they produce that piece of equipment and service it, they are required to record those numbers. Don't ask me why. This is, again, one of those bureaucratic things that you don't want to get an answer because you may not like the answer, but it's not much you can do about it. Okay, number 13. Since blood bank equipment is not included in the CMS not eligible for AEM list, besides the lab equipment, one can deviate from the respective OEM's recommended maintenance frequency or procedure. True or false?
Okay, we've got 23% true and 77% false.
Okay, let's see what is the right answer. False. Again, it is true that CMS did not say anything about it. However, there is another agency, sister agency of CMS within the Department of Health Human Services called FDA. And the FDA has a Center for Biological Evaluation and Research that has jurisdiction over blood and blood products, and therefore over the blood banks. And they have this specific requirement within its compliance program guidance manual that states that during the inspection, the inspector should determine if the establishment performs equipment maintenance according to equipment manufacturer's instructions and the establishment's own SOPs. So sorry, you have to do it because it's not very common. FDA does not come around that often, but if they come to your blood bank, you could be in big trouble. Okay, Linda, should I stop here because I think we are at the Q&A period already, right?
Yeah, we've got about 10 minutes left. I've got a couple of questions come in, so it's up to you whether you want to do another test or we go on to the CD question, the question.
I think I've already annoyed enough people, so let me just run to the very end to provide my acknowledgements and close the thing. So let me show this. The material presented here was extracted mostly from a book that was actually I wrote, was published by BSI. So I appreciate the authorization to use it. There are many collaborators that contributed, but I'm solely responsible for the mistakes, and I thank you for your attention today.
Okay, do you want to keep that last slide up so people can see your email in case they want to contact you directly?
Oh, geez.
That's
hey, don't send me mail bombs, please, okay?
People are loving this. So I've got a couple of questions here. The first one is, what do you think that TJC will do in revising its standards to conform with the conditions of participation?
Jeez, you had to ask that question. I asked that question during AMI conference to Herman McKenzie, and he could not answer that question. So you think I am smart enough to answer that question? The bottom line here is that they have been told by Joint Commission leadership that they have to slim down the requirements and the standards to really match the expectations of CMS, more specifically the conditions of participation. And if you bother to dig that out and read for yourself, you will see that the conditions of participation are very, very limited short statements, and most of those statements are actually statements of principles. For example, let me just show you one here. I hope you can see my screen here. The physical environment, the only statement that's there is facilities, supplies, and equipment must be maintained to ensure an acceptable level of safety and quality. That's it. There are other things about radiological equipment and nuclear medicine equipment, as well as reference to NFPA 99. Okay, but that's it. So I honestly don't envy Herman and his team that need to revise that standard, because this is going to be a heck of a revision that they have to do. But on the other hand, we applaud this initiative because to some extent, Joint Commission historical has been a little bit overwhelming, requiring a lot of details. So I think this will help us slim things down a little bit. Thank you.
Okay, well, this is a very interesting question. Do you believe AI will replace BMETs and HTM professionals soon?
No, I don't think that is the case. AI is not there yet, and I don't think it's going to be there even in about 5 years. Some things, however, will happen and is already in progress. Certain large imaging companies, manufacturers should say, have already started to look into the failure codes generated by their internal self-test software and using that to make predictions using not exactly AI, but machine learning strategies to make forecasts of what needs to be done. For example, when is the right time to replace the X-ray tube in CT scanners? Much the same way the aircraft manufacturers and turbine makers are doing right now to help reduce the downtime, the ground time of aircrafts, so they can forecast what needs to be done as soon as the aircraft touches down. They take the aircraft to the hangar and do whatever is necessary so the turnaround time can be expedited. So this will happen. However, more importantly, my prediction is that you guys are going to be replaced by someone with a high school diploma, a driver license, and the supreme ability to use a computer and a cell phone. He or she does not need to know anything about electronics, hardware, software, anything else. They just need to go to the place with the hero kit in hand, turn on the machine, plug the computer in, and see the error code and what is the manufacturer recommendation to deal with that error code. Replace number A, replace number B, replace number C, and if all fails, you pick up the cell phone and call corporate office and they will tell you what to do. And that is not only to significantly reduce the costs of those technicians, also increase the number of available technicians, and also, let's face it, reduce the number of potential competitors to the manufacturers in the market. Because if they don't train you, they take away your computer, they can take away your phone, that doesn't help much, but they will not answer your phone anymore. So at that point, my friend, you are useless. You might as well go to find a job with Uber or etc. Although I hate to say, Uber may decide at that point to use autopilot, and then you still be without a job. Did I aggravate you guys enough?
Well, I've got a similar question that's just come in. Do you think, as years ago, when electronics and mechanical combined to form mechatronics, biomedical engineering and information technology will combine since the two are becoming intertwined?
No, that's too short-sighted. My forecast is that, unfortunately, I'm too old to benefit from it, but you young guys are likely to see something called genetic engineering come into play, and at that time, there will be dramatic changes to healthcare. Today, we talk about organ transplant, artificial organs, etc., etc. There will be no such a thing in the future. In the future, they will grow your own heart to replace your debilitating heart. They will grow your own kidney, a brand new one using your own tissue. Why we need artificial organs? Why we need transplant? You have troubles with organ rejections and all those nightmares. The only minor problem here is that in that same process, you may create a creature, for lack of a better word, I would call Frankenstein, that is a laboratory created being. I'm not going to call that human being, it's a Frankenstein being that will look at us and say, you guys are dumb, slow, and also prone to great problems like, harming the environment, destroying the planet, killing each other, etc., etc. So why do we need you guys? That is the ultimate replacement for human beings, my friends. And as I said, maybe unlucky of me benefiting from genetic engineering, but lucky me, maybe I don't get destroyed by one of those creatures in the future. If I did not annoy you enough with this answer, I think I better hide in Area 51 here in Nevada.
Well, we're coming up to our hour, and thank you so much, Bin Singh, for your time today and for such a great and fun presentation. I'd like to encourage everyone to visit today's sponsor to learn more about the products they provide for our industry. So please visit us.sodexo.com/HTM. As promised, the answer to today's trivia question is Florida. So congratulations to our winner, Janice Courtois. Just a quick reminder to obtain your CE certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit from the ACI, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be back next week with another webinar, so please visit webinarwednesday.live for more details and complimentary registration. Thank you once again for your time today, and enjoy the rest of your day.
Thank you for putting up with me.
Thank you, Bin Singh.